class number 2 of the course of Vascular Ultrasound and Echocardiography Introduction of the Florida National University. What control the circulation? What mechanisms use the body to control the different quantity of blood that we use in different situations? In other words, what is the organ that make the decision of how much blood is going to use the body in a different situation? Sometimes when it's in exercise, when it's not in exercise. The control of the systemic circulation is because there are different arterial tone in different organ depending of the quantity of blood that the organ is using in this moment. In other words, the necessity of different organs to use different quantities of blood is the control of the systemic circulation. This is called arterial tone. Arterial tone define how much blood one organ or all the body is going to use in different situations. Arterial tone determine blood flow in the capillary beds, depending is vasodilatation, normal vascular tone, or vasoconstriction. In vasodilatation, they let pass a lot of blood. In normal, the quantity of blood is in the middle, and when there are vasoconstriction, there are a little of blood flow, depending of the arteriolar tone. What controls the systemic circulation? When there are vasodilatation, a lot of blood is moving through the arterioles. When is a normal vascular tone, this is intermediate, and when there are a vasoconstriction, very little blood flow occur in the arterioles. Arterial tone determine blood flow to the capillary vents, depending if there are vasodilatation, a lot of blood flow, normal blood flow, or vasoconstriction with a little quantity of blood flow. The blood flow is the body is controlled by the arteriolar tone, depending of the quantity of arteries that are in vasodilatation, the quantity of arteries that are a normal tone, and the quantity of arteries that in this moment are in vasoconstriction. The summatory of all the arteriole of the body control the quantity of blood flow of the organism. Factors that change the arteriolar tone. There are different factors that control the arteriolar tone. One of these is the autonomic control, the sympathetic and parasympathetic nervous system. Other is the hormones, the different actions that have hormones over the arteriolar tone. These hormones are adrenaline, cortisol. Other hormones also produce change in the arteriolar tone. The most important are adrenaline, endothelium-derived factor. This is factor produced by the same endothelium of the arterioles. In general, endothelium-derived factors are always vasodilators. And the local concentration of metabolite, that is the most important control of the circulation in the organs, are caused by the accumulation principle of CO2, but other metabolites also can produce vasodilatation. Normally, the concentration of metabolites is directly proportional to the vasodilatation of the arteriole. More concentration of metabolites, more vasodilatation occur in the arterioles of determined tissue or organ. Autonomic control, sympathetic and parasympathetic. Autonomic fibers under the control of the vasomotor center in the medulla can act in both sides, can be sometimes vasoconstrictor and sometimes vasodilatators. Autonomic control, sympathetic and parasympathetic. Circulating hormones. Hormones normally in the circulation have the function in general of be potent vasoconstrictor, like adrenaline produced by the suprarenal gland and angiotensin II that is produced by the kidney. Circulating hormones have a big part of the responsibility of the quantity of blood that circulate in each organ or each tissue in different situations. Endothelium-derived factors in general are vasodilators, are the typical factors that are secreted by the cell of the endothelium when there are trauma. Endothelium-derived factors play a role in controlling local blood flow and include prostacyclin, nitric oxide, both potent vasodilators. And the most important, the local concentration of metabolites, the local concentration of CO2. This is the most important. Remember that CO2 is the product of cellular breathing. When CO2 is accumulated, that means that the tissue needs more oxygen, and that open the arterioles, let pass the blood take away the CO2 and put new oxygen for the respiration of the cells. The most important control of the circulation in the body is the concentration of metabolite CO2 in the tissues. In general, metabolites cause vasodilatation. When metabolite concentrate too much, that produce vasodilatation in the arterioles. This response is probably the most important of the control of the circulation of the blood flow in organs and tissues. This is the first law that we must understand in vascular. It's the Poiseuille law. It's not a medical law, it's a physical law. And this physical law says that the velocity of a laminar flow is directly proportional to the pressure gradient, the difference of pressure in the different size, and the square of the ratio, and inversely proportional to the length of the tube and the viscosity of the fluid. We are going to explain the Poiseuille law point by point. Poiseuille law. Flow is equal P gradient pressure and the radius of the vessel at the 4 divided by 8 viscosity and longitude. In other words, directly proportional to the pressures, directly proportional to the square of the radius. More is the radius, more is the flow, and inversely proportional to the viscosity of the blood, that always is the same, and the longitude of the vessel, that is not possible to calculate in the human body. To repeat, flow of blood is directly proportional to the pressure gradient and the force potency of the radius, and inversely proportional to the viscosity of the blood that in general remain the same, and the longitude of the vessel that is not possible to calculate in the human organism. Velocity of a laminar flow is directly proportional to the pressure gradient, letter P, and the square of the ratio. Ratio is very important, is the most important for us, is ratio, and inversely proportional to the viscosity and the longitude of the vessel. Volume flow is proportional to the 4 power, this is very important, 4 power of the ratio, so even little change in the ratio produce big change in blood flow. The most important in vascular is the radio of the vessels. Little is the radio, less blood flow. Change in radio of the vessel and difference in the pressure gradient are the principal cause of disease in the blood flow, but change in the pressure are disease of the heart. And change in the radius and the part of vascular that we are interested. Change in pressure, heart. Change in radius, vascular problems. 10% of decrease in the radius of the vessel produce 35 decrease in blood flow. 50% decrease in the radius produce 95% decrease on the blood. It's very important to look in the relation between the decrease in the radius and the flow. Very big. Only 10% decrease in radius produce 35 decrease in blood flow. But when you have more, 50% decrease in radius produce 95 decrease in blood flow. 50%, 95 decrease in blood flow. The relation between the radius and the blood flow is directly proportional. More is the radius, more is the blood flow. On the contrary, less is the radius, less is the blood flow. 50% of the radius diminution is equal 95% decrease in blood flow. Velocity of a laminar flow is directly proportional to the pressure gradient and the square of the ratio, and inversely proportional of the length of the tube and the viscosity of the fluid. Here is the formula. Flow is equal gradient pressure difference and the radius of this. A time the viscosity and the longitude of the vessel. Remember, viscosity in the blood rarely change, and the longitude is not a variable that we can quantify in an organism like the human. If you moving the pressure gradient to the other side of the equal, remember here is in multiplication, go in division. Flow divided by the gradient is equal P radius square A viscosity and longitude. The only change if we put the pressure gradient in the other side of the equation. You have here flow divided by pressure gradient is equal P radius square divided by A, viscosity and longitude. Invert, change the, put, this is in division, in multiplication, invert, this is mathematical possible, and you change the equation for this. The gradient of pressure divided by the flow is equal A times viscosity and longitude, and divide by P radius square. And this is equal to resistance. The gradients divided by the flow is equal the most important parameter we are interested. Resistance, depending of the pressures and depending of the quantity of flow, we can determine what is the resistance. And remember that the resistance is the disease, because when there are a diminution of the radius of the artery, there are more resistance, and if there are more resistance, less blood is going to the tissues. Remember the electrical formula that says that the voltage is equal to intensity multiplied resistance. This is called the Ohm's law. And remember that is voltage is equal to the pressure gradient, and intensity is equal to flow. If you change the order and you have voltage over intensity is equal to resistance, exactly like voltage is the same as pressure gradient, and the flow is equal to intensity. In other words, with this formula, pressure gradient over flow is equal resistance. We have the formula of resistance, and the formula of resistance is equal 8 viscosity longitude divided by P radius square potency. Resistance O, viscosity longitude, radius at elevated 4 potency. Bernoulli principle is the principle that states that the velocity of the blood is more when the narrow of the artery is present. Bernoulli principle states that for an inviscid flow, an increase in the speed of the fluid occurs simultaneous with a decrease in pressure or decrease in the fluid potential energy. This is look a little complex, but really Bernoulli law explains what is the reason that the blood moving faster in the areas where there are a narrow in the artery. When there are a stenosis, more is the stenosis, more is the narrow of the artery, faster moving the blood in the area. You have here that the product of the potential and the kinetic energy in a pipeline is the same, even there are different radius. You have in this area potential energy and kinetic energy in this point is equal than potential energy and kinetic energy in this point. Pressure, that is potential energy, multiplied by the velocity of the blood, is exactly the same in any point of the pipeline independently of the narrow, and this is for that the velocity in the narrow area is more because the pressure is less. Pressure and velocity always is the same independently of the narrow of the artery, and this is that Bernoulli law explain why blood velocity is more when there are arterial stenosis. Normal flow in the arteries is laminar. In other words, all the blood is moving in the same direction with the same velocity. Blood moving concentrical layer, the fastest flow is more or less in the center stream, while the flow along the wall is more sluggish, but even the difference is very little. In general, in laminar flow, all the blood is moving in the same direction and at relative same velocity. Laminar flow has a narrow range of velocity. In other words, all the blood is moving at similar velocities and in the same direction. Of the contrary, turbulent flow have a wide range of velocity. Why? Because the blood is moving in different directions and at different velocities. This is turbulent flow, is not the normal flow, it's pathological. Sometimes it's normal, but after stenosis there are also turbulent flow. The factors that affect the development of turbulence are expressed by the Reynolds number. Reynolds number is the number that determines the presence or the potentiality to have turbulent flow. When the Reynolds number is more than 2000, there are turbulent flow. The factors that affect the development of the turbulence are expressed by the Reynolds number. We are going to review the Reynolds number, but the most important to remember about the Reynolds number is the number 2000. More than 2000 mean there are turbulent flow. The Reynolds number depends directly of the velocity of the flow. More velocity, more chance to have turbulence. The density of the fluid, and 2 times the radius, and inversely proportional to the viscosity of the flow. But remember that the viscosity of the flow in the blood rarely change, always is the same viscosity. That change is the velocity and the radius of the artery. V is velocity, directly proportional. Q is density, also directly proportional. R is the radius, also directly proportional. More is the radius, more chance there are for turbulence flow. And the last one is viscosity, that in general always is the same in blood. Laminar flow tends to be disturbed if the Reynolds number exceeds 2000. This is the importance of the Reynolds number. 2000 is the Reynolds number that predicts the presence of turbulence. Doppler effect, the change in the observed frequency of an acoustic or electromagnetic wave due to relative motion of the source and the receiver. Remember that the Doppler effect is about frequency. Frequency is the important in the Doppler effect. The difference between the frequency of the echo and the frequency of the pulse are the Doppler shift. The Doppler shift is directly proportional to the velocity of the red cells. More is the Doppler shift, faster are moving the red cells in the blood flow. Positive Doppler shift when the red cells are moving to the transducer. Positive shift, received frequency except transmitted frequency. Red blood cells are moving to the transducer. Negative Doppler shift is the contrary. Negative Doppler shift, received frequency is less than transmitted frequency. Red blood cells are moving away to the transducer. Doppler shift units are hertz, And here there are no Doppler shift because even the red cells are moving. The ultrasound is perpendicular to the red cell movement. No Doppler shift when the direction of the red cells is perpendicular to the direction of ultrasound. In clinical study, Doppler shifts are in the audible range, and this is the reason the machine produces a sound that is the same Doppler shift that is in the audible range. Measured velocity must be compensated with the angle of ultrasound. In other words, you measure the velocity, you compensate with the angle that you are using, and the maximum angle of compensation for arteries are 60 degrees, and that gives you the actual velocity. You measure the Doppler shift, you compensate with the angle no more than 60 degrees, and you get the actual velocity of the blood in the point that you are interested. The Doppler equation is the mathematical equation that gives the velocity of the blood. And this is the Doppler shift of the Doppler frequency is equal to times the original frequency of the transducer, the velocity of the red cell, the cosine of the angle that you are using, no more than 60 degrees, remember, and the propagation speed of ultrasound in soft tissue. And when you change the formula to get the velocity, you have that the velocity, that is the most important parameter that we are calculated, because depending of the velocity depend the narrow of the artery, that we are interested to know how much is the artery narrowing. The velocity of the blood is equal to the Doppler shift times the propagation speed of ultrasound in soft tissue divided by 2, because it's an echo, the original frequency and the cosine of the angle that you are scanning, and cannot be more than 60 degrees when calculate the velocity of the arteries. Velocity of the blood is equal the Doppler shift times the propagation speed in soft tissue divided by 2 times the original frequency and the cosine of the angle you are using. Doppler tips: use a little gate, put the gate at the center of the vessel, and rotate the angle parallel to the vessel wall, but remember, the angle cannot be more than 60 degrees to scan arteries. Doppler ultrasound is the system that we use to scanning arteries and veins. It's a combination of end mode and spectral Doppler. B mode, the cursor that is here with the gate, and the spectral Doppler, that is this area here, is a function between time and velocity. Spectral Doppler transducers are pulsed transducer or are also continuous transducers. Continuous transducers have the advantage that can measure any velocity of the blood, but continuous wave have a disadvantage. Continuous wave cannot produce anatomical picture. Continuous wave cannot produce 2D pictures, and this is for that when you measure the velocity with continuous Doppler, you have the exact place where you are measuring. The advantage that you can measure any velocity, and the disadvantage that you are not exactly sure what area are you taking the velocity. Doppler shift arises all along the length of the beam. The spectrum produced by continuous wave system display Doppler shift created by any blood cell intersecting the path of the zone beam. This is called range ambiguity. This is range ambiguity. You are measuring the velocity, you have the velocity, but you don't know if the velocity that you are measuring is here or is here. If there are two vessels, you get always the maximum velocity, but you don't know what artery is the artery with this maximum velocity, because continuous ultrasound do not produce image. This is called range ambiguity. You are getting the velocity of the red cells or the blood, but you don't know exactly what is the vessel that you are scanning. Pulse Doppler's significant disadvantage is aliasing. When you have very, very high velocities, this is impossible to measure with pulsed ultrasound. The high velocity appear in the negative side. High velocity appear negative. This is called aliasing. It's the most commonly artifact in pulsed Doppler imaging. The aliasing appear when the Nyquist limit is more than the pulse repetition frequency. Pulse repetition frequency divided by 2 is the Nyquist limit. When the pulse repetition frequency divided by 2 is more than the Nyquist limit, this is when appear aliasing. Diagnostic of arterial obstruction. The most important in the diagnosis of arterial obstruction is the increased stenotic zone velocity. Systolic or diastolic. More important systolic. More is the velocity in the stenosis, more is the percentage of narrow velocity of the blood, and stenosis are directly proportional. More stenosis, more blood velocity. Other characteristic is the turbulence after the stenosis. There are no laminar flow after stenosis. Other change are more pulsatility before the stenosis and the vasodilatation that happen and is naturally to the little quantity of blood flow that take the tissues. Indirect effect of obstruction, very little blood flow that produce vasodilatation. But the most important is the increment in the velocity in the area of stenosis, and the most important is the systolic increment in the stenotic zone velocity. Color flow imaging is an attractive, not to say seductive modality for looking the vascular system. Color Doppler help a lot, give a lot of information, and the most important, let you know where is the area that you want exactly measure the blood velocity. You can see anything that you see in spectral Doppler is also in color flow. If you have a very pulsatile artery, you can see in the color flow. If you have turbulent flow, you can see in the spectral, you can see also with the color Doppler. You can see accelerated flow, turbulent flow, and normal systolic and diastolic component that relate to the event of the spectral analysis. In other words, the same that happen in spectral analysis is the same that happen in color Doppler. But the advantage of spectral analysis that spectral analysis quantitative, you can measure the velocity in change. Color Doppler is qualitative. They show you the quality of the blood flow, but you cannot measure. You can see the stenotic yes and place the spectral sample volume accurate for measure the maximum velocity. You can see in the picture, you look in the area of stenosis and you put the velocity gauge in this area to measure the velocity in the area of stenosis. More is the velocity, more is the narrow of the artery. It is not quantitative, and this is the problem of color Doppler. You cannot calculate stenosis. You can recognize there are stenosis. You can see the turbulent flow after the stenosis, but you cannot calculate because color Doppler is not quantitative, it's qualitative. Color Doppler is based in pulsed ultrasound because color Doppler produces image, and the only ultrasound that produces image is pulsed ultrasound. In other words, continuous Doppler have no image, continuous Doppler have no color Doppler. Power Doppler is a special Doppler that don't give you the direction of the blood, and this is the reason use only one color. The color is gold. If there are blood flow, the machine put a color, but the machine don't let you know what is the direction of the flow. In arteries, each site of cardiac activity produces a distinct way on the Doppler frequency spectrum. This is each heart beating, systole, diastole, systole, diastole. Each cardiac cycle produce one wave. Detailed waveform refers to the shape of each of these waves. This is a typical wave in the common carotid artery, and you can see here that the most important are the peak systolic, the end diastolic, the window that is the inner part of the wave, the envelope that is the outer part, and here the carotid notch that represent the closure of the aortic valve. You can see here that the same level of the carotid notch is the separation between systole and diastole. In other words, the carotid notch is the closing of the aortic valve and separates systole, because remember the aortic valve is open in systole and closing in diastole. Peak systolic, end diastolic, envelope, window, the carotid notch. The Doppler waveform defines a flow property called pulsatility. Doppler waveform have low pulsatility, moderate pulsatility, or high pulsatility, depending on the intensity of the heart beating. A normal spectral display from the external carotid artery, that is artery that gives blood to the bones and muscle of the face, is different because have a high resistance, and the high resistance can be demonstrated because the diastolic flow is very little, near zero. In other words, in the arteries of high resistance, only there are blood flow in the systole, not in the diastole. This is the most important characteristic of the high resistance artery, that in general are the artery that give blood to the bone and muscles, and the muscles one are not in use. External carotid artery, you have here peak systolic, end diastolic, window, envelope, and the carotid notch. External carotid, high resistance artery with little blood flow during diastole. You can see here peak systolico and diastolic, dicrotic notch, envelope and window, external carotid artery. Of the contrary, the internal carotid artery is a low pulsatil artery because give blood to the brain, and the brain is a low resistance organ that get blood in systole and also have blood flow in diastole. Low pulsatil Doppler waveform have broad systolic peak and forward flow through diastole. You can see here broad systolic peaks and a lot of blood during diastole. A lot of blood is moving. Remember, this is the velocity, and the velocity of the blood in diastole is high when the arteries are low resistance arteries, as internal carotid artery that give blood to the brain, an organ that use a lot of blood always. The internal carotid artery have a left sharp upstroke and peak and a lot of diastolic flow. A lot of diastolic flow. The dicrotic notch is usually not special discernible, but you have here all the elements: peak systolic and diastolic, window and envelope. The renal internal carotid artery, all the arteries to the visceral organs are always low resistance and have a lot of flow during diastole. Remember, high resistance artery that go to the bones and the muscle not in use have high resistance and very little flow during diastole. This is a low resistance arteries. Are always monophasic. That means that never go negative because flow go only in one direction. This is characteristic of low resistance arteries like internal carotid artery. Internal carotid artery, round peak, a lot of flow during diastole. This is the characteristic of low resistance arteries. You have here a low resistance artery and you see that the flow in diastole is high. Internal carotid artery, low resistance, a lot of flow during diastole, low resistance artery. Common carotid artery have element of post branch, sharp upstroke and peak, well-defined dicrotic notch and lot of diastolic flow. In other words, it's a combination between high resistance and low resistance. This is the common carotid artery, but in general some people say that the common carotid artery is also a low resistance artery because the majority of the blood flow of the common carotid artery is going to the internal carotid artery that is really a low resistance artery. Moderate pulsatility, Doppler waveform have an appearance between the low and high resistant waveform, but remember a lot of authors classify the common carotid artery as a low resistance artery. Common carotid artery is peaky, exactly like the ECA, but have diastolic flow like the internal carotid artery. It's a combination between the internal and the external. It's a combination of a high resistance artery, external carotid artery, with an internal carotid artery or low resistance artery. You can see here the picture of the common carotid artery. Normal flow in the legs and in the upper limbs are multiphasic. In other words, go negative. The direction of the blood flow change when there are the final of the systole, the beginning of the diastole. In other words, have three parts. One is this, two negative, and three positive. In other words, is multiphasic or triphasic. There is a charged systolic component, a brief reversal of flow, this one here, reversal of flow due to the high distal resistance, and then another brief rebound forward. In other words, are multiphasic because are high resistance arteries. Leg artery, you can see, is triphasic, 1, 2, and 3. Leg artery, multiphasic or triphasic, high resistance. Exactly the same happen in the upper limb arteries, are also multiphasic. Damped waveform occur after stenosis, when there are a disease called atherosclerosis and there are stenosis in the arteries of the lower limb. The wave after the stenosis become damped with round peak systolic and also have high velocities in diastole, produced by the vasodilatation of the leg if there are ischemic disease. In other words, after stenosis, the shape of the wave change is not more triphasic, become monophasic and with high diastolic velocity. Post-stenotic artery, less amplitude and low peripheral resistance due to the ischemic of the tissue. This is different number to measure different characteristics. One is called the pulsatility index. It's an arterial blood flow velocity waveform index designed to quantify the pulsatility of oscillation of the waveform. In other words, the energy of the intensity of the pulse. Pulsatility index describes the intensity of the pulse is equal to the peak systolic less the negative part divided by the average velocity of the wave. The pulsatility index only can be calculated by the ultrasound machine because the mean velocity is a parameter that can only be calculated by the computer of the ultrasound machine. Pulsatility index, peak systolic less the negative side divided by the average of the mean of the velocity that indicate the intensity of the wave. Pulsatility index, A minus V divided by the average. Mean is the average of velocity, and this is the reason the pulsatility index is calculated by the computer of the ultrasound machine. Resistive index is easy, you can calculate yourself. Resistive index is equal the systolic less diastolic divided by systolic. Resistive index is a simple parameter that can be derived from ultrasound Doppler spectrum. You don't need the calculation of the machine, only take the peak systolic, take the end diastolic, and you can calculate the resistive index. A minus V divided by A. In other words, peak systolic minus end diastolic divided by peak systolic velocity. Systolic diastolic ratio is even easy. It's only the relation, the ratio between the peak systolic and the end diastolic. A divided by B. In other words, the pulsatil index, the resistive index, and the last one and the easy one, the systolic diastolic ratio. Acceleration is the quality of the pulse to get the maximum velocity. Is another important flow feature evident in Doppler arterial waveform. In normal situation, flow velocity in artery accelerate very rapidly. In systole, and the peak systolic is reached in a few microseconds. In other words, it's very fast between the end diastolic and the peak systolic. The acceleration normally is very rapidly. In severe arterial obstruction, of the contrary, the acceleration diminishes, may be slowed after stenosis. Quantitative measurement of acceleration is achieved with the acceleration time and the acceleration index. Acceleration time is only the time from the end diastolic to the peak systolic, only the time to the end diastolic to the peak systolic, and the systolic acceleration index is the division between the change in velocity and the change in time. Acceleration rate or acceleration index, the change in velocity divided by the change in time. You can see here change in velocity, change in time. The Ankle-Brachial Index is a simple, reliable mean for diagnosis peripheral arterial disease, and it's very easy to take. Blood pressure is measured in the arms and also is measured in the ankles and have a relation that cannot be less than 0.9. When there are 0.9, that means that there are peripheral arterial disease, with the exception of the people that have diabetes, because the people that have diabetes was not easy to take the pressure with a cuff because arteries are calcified. The Ankle-Brachial Index test is simple enough to be performed in any place for any nurse, doctor, or sonographer. The ankle-brachial range is generally considered normal from 0.95 to 1.2. Less than 0.95 is the beginning of the peripheral arterial disease. Not only the Ankle-Brachial Index is one of the most reliable tests for peripheral arterial disease, is also very little expensive, very easy to do. Also, the Ankle-Brachial Index is extremely reliable. This test may not be accurate in all patients, and this is that I'm talking patients with diabetes have the arteries calcified, and you can get wrong measure of the arterial pressure. Segmental pressure is similar to ankle-brachial pressure, but it's more complex because they put more cuff. There are sometimes with 3, with 4 cuff, depending of the study. It's similar to the ankle-brachial test with the addition of 2 or 3 additional blood pressure cuff. Cuffs are placed just below the knee, and 1 large cuff or 2 narrow cuffs are placed above the knee and the upper right. They measure the change of pressure in each area. Using the Doppler instrument, blood pressure measurements are taken. You can see here they put pressure in the cuff, and with the continuous Doppler take the signal when the artery reopens. At the same time, you are putting less pressure in the cuff. Plethysmography is a test used to measure change in volume in different parts of the body. The change in volume helps to check blood flow in many body parts. The change in volumes represent change in pressures. The most important technical consideration is to know that the cuff is exactly the cuff that needs the person that you are studying. Because if the cuff is too little or the cuff is too big, the measures are not be accurate. Advantage of plethysmography include is easy, is reproducible, have less artifact than Doppler technology. Normal plethysmography waveform characteristics are exactly like Doppler, but remember, plethysmography is not the same as Doppler because Doppler is velocity and plethysmography is volume or pressure but not velocity, but the form of the wave is similar with the exception of the negative side. Plethysmography measure pressure, never there are negative pressure inside the vascular system of the body. Brick systolic substrate, exactly like Doppler, sharp systolic peak, gradual downstraight component, and the dichrotic notch, exactly like the Doppler waveform. But remember, the Doppler waveform is about velocity and the plethysmography waveform is about pressures. The anacrotic limb, that is called the brick systolic upstroke, the sharp systolic peak, exactly like the Doppler waveform, the gradual downstroke component, that is called the catacrotic limb, and the dichrotic notch that represent, as in Doppler, the closing of the aortic valve of the heart. You can see the comparison between the plethysmography wave and the Doppler wave, and are similar, but there are a big difference. Plethysmography have no negative side, no negative pressure is not possible. In continuous Doppler or pulsed Doppler, yes, because it's velocity, it's reversed velocity, but not in plethysmography, but in other areas are very similar, peak systolic and end diastolic. The primary distinction between normal limb and extremity with peripheral arterial disease is that the dichrotic notch disappears. The first thing that you can see when there are peripheral arterial disease in a plethysmography way is the disappearance of the dichrotic notch, which increase disease, the severity. This is a declining acceleration time, exactly like Doppler, and lower peripheral resistance. Post-stenotic artery. Abnormal plethysmography waveform that accompany increased disease severity include prolonged upstroke, logical because there are less acceleration time, rounding the systolic peak because there are a low peripheral resistance, and the waveform downstroke away from the baseline. You can see here prolonged upstroke. This is the acceleration. You can see here the inclination is less in different areas, less inclination in the normal, more flat when there are disease. Rounding of the systolic peak, more is the disease advances, more flat are the waves, rounding the systolic peak. Waveform downstroke away from the baseline. This is normal with this concavity from here. This is normal concavity. This is abnormal concavity away from the baseline. This is other condition that appear when there are moderate peripheral arterial disease. Around the systolic peak with a major delay in systolic upstroke is indicative of significant stenosis. You can see here the difference, and the most important, the amplitude of the wave is less and less and less depending of the advanced that is the disease. Other factors that can affect waveform amplitude: the patient position, edema, obesity, blood pressure, blood volume if the person is in good hydration, the vasomotor tone that can be affected by medicaments, and the situation of the heart. The heart is working normally or abnormally. All of other factors can affect the waveform amplitude. The most important of all for me is the ventricular stroke volume. Even if there are not stenosis, if the heart have no enough potency, waveform can appear with little amplitude, even there are no stenosis, because the list is other factors that can affect waveform amplitude. Photoplethysmography is a special form of device that is based on the principle that light is attenuating in proportion of the quantity of blood that is present in the continuum of tissue. They can measure systole and diastole through the concentration of blood in the tissue. Goodbye.